Dacravane's Tenosynovitis.
Dacravane's Tenosynovitis.
Dacravane's Tenosynovitis.
Going to talk about a relatively common cause of wrist pain, but one that's not particularly familiar to many physicians or PAs or MPs, and it's called a specific type of tenosynovitis called Dacravane's Tenosynovitis, probably named after Dr. Dacravane. It causes significant wrist pain, and oftentimes the patient tries to make up a trauma for it, but its cause is unknown, thought to be maybe due by overuse. It used to be called wringer washers hands because you would go like this a lot in washing clothes, and it's a tendonitis of two tendons on this part of the wrist, the radial part of the wrist. Quite painful, tender to touch, and it decreases the use of the hand. So if you try to get something off of a wall or a book out of a bookcase, you oftentimes drop it. It hurts to move the wrist up and down, and when you look at it, it looks relatively normal. Sometimes there's a little bit of soft tissue swelling, but usually it looks normal. Because the patient often thinks there might be trauma there, an x-ray is sometimes done, but the x-ray is always going to be negative. It doesn't show anything on the film. The problem is that it's an inflammation of two tendons that are over the radial styloid, about this far, and it causes an inflammation of those tendons, and in severe cases where it's there for a long time, you can get stenosis of the tendons. The radial styloid is sort of the marking spot for where those tendons rub against a prominence, and therefore that's one of the places where it hurts. The diagnosis is relatively easy once you get the patient to localize the tenderness area. They usually say their entire wrist hurts, but when you get them to calm down and you get them to basically say exactly where it hurts, it's always on this side of the wrist, and there's not much else that causes pain up in that. The way you diagnose it is to move the hand down like that to stretch those tendons, and that often causes them to jump or say, ouch, that's where it hurts. And there's a specific test called the Finkelstein Test, where you put the thumb into the fist and you go down like that, and that causes the patient to have pain. And that's because it pulls these tendons where the inflammation is, usually to the two tendons that are over there at the base of the thumb. The treatment, you can try some non-steroidals or rest or splinting, but usually the treatment is relatively simple, straightforward, and also very effective, and that's an injection with corticosteroids. The quickest and best treatment that usually produces a cure is to inject the area of the tendonitis with a long-acting corticosteroid. In this case, we're going to use DepoMedrol, which is a methylprednisolone acetate. It's the cloudy solution that's used for an intramuscular or a periarticular or intra-articular injection, a long-acting corticosteroid. You could also use Kenalog, which is a similar product. The dose is probably 40 to 60 milligrams, and you mix it with 1% lidocaine, and that gives you both volume, so you can spread it out over a wider period. Also, you can, it causes it not to be painful because you'll get the numbness. One of the reasons for using the lidocaine is that the area should be numb, and that will tell you whether you have the medication in the right area or not. So after the procedure, the patient should, at least for a temporary time while the lidocaine is still active, they should lose the sensation of the pain. You want to have your patient either sitting down or lying down because they get injected with a needle, and sometimes they get a little bit of vagal activity from that. So the problem is that this patient has tenderness over here. There's the radial styloid. The Finkelstein test, where they put the thumb in the palm and bring it down, causes them to wince in pain. And then you ask them to use with their finger what area the tenderness is. So you tell me where I start.
There.
Right there. And you sort of mark it there. And where I end.
Ow, 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 ow. Back a little. There.
Okay, and that's about where it ends. And that's usually a standard area for Dacravane's tenosynovitis to affect. So we're going to inject the two tendons that run in that area right over the radial styloid. So your first injection will be in there, and we're going to use a long 25 gauge needle. So your first injection starts here. Sometimes you can get the entire area with one needle injection. Otherwise, you start down here, inject it a little bit, and then you go through the already numb area and inject it up a little bit further. Lidocaine, probably about 3 cc's of lidocaine. And then squirt that into the DepoMedrol bottle, and you'll come out as a cloudy solution. This is 40 milligrams per ml. That should be enough for this particular area. In this case, the patient's lying down because you're going to inject her. So you hold the wrist such as this. Now here's your marks of where the tenderness is. Just get a little bit of alcohol wipe. You've got 3 cc's. You shake it up because that stuff tends to go down, and you find out again where it's tender. Move it around a little bit. That should be about it. It takes about 3 to 4 days for all the pain to go away, and sometimes there's a post-injection flare, which means in 12 to 24 hours it hurts more because of the corticosteroid injection. So generally you have the patient take 2 Advil 4 times a day, or 600 milligrams 4 times a day of Motrin for the first 2 days while the cortisone is working. Generally cures the problem.
My hand feels numb.
Well, the radial nerve comes across here, so you will get some blocking of the distal sensation. So oftentimes this area will feel numb. It'll wear off in about a half an hour as the lidocaine wears off. But now you test it to see if, in fact, there's pain, which she jumped before last time I did that. You can see the soft tissue swelling. Now that's a fair amount of lidocaine and steroid in there because you don't know exactly the area that you're injecting. Again, the Finkelstein test is no longer painful. Shows that you're in the right spot with your lidocaine and cortisone mixture. To reiterate a few concepts, in my experience this is most common in women. Occasionally men get it, but it's almost entirely in women. You can have gonococcal tenosynovitis in young women that can give a tendinitis, so you want to be careful that there's no fever with this. If you ever do a white count, it should be normal, and there should be no little spots from emboli from tenosynovitis. When you're doing your injection, you're not injecting the tendon itself. You're injecting the peritendinous area, so it's in the soft tissue of the wrist. So when you're injecting your steroid, if you feel that there's a lot of resistance to the needle, you may be in the tendon. So you pull it back and redirect it. It should go in very, very easily. The tissue should expand, and if you use a generous amount, you don't have to be that accurate. But don't inject the tendon itself. You cannot easily inject a tendon, so you'll know when you're pushing in the syringe that you're in the tip of the needle is in the tendon because it won't go in. So don't force it in. It should go in really easy, a large amount of soft distendal tissue where you're going to be injecting.
Finkelstein Test.